Good evening, everyone. Thank you so much for joining us. We are just going to give everyone some time to log on and we will begin shortly. Good evening, everyone. Thank you so much for joining us. We'll be getting started in about a moment. Let's just give everyone a chance to log on. Okay, good evening once again. Thank you for joining COVID-19 Vaccines and Pregnancy. Tonight we will be discussing what you need to know, and I will now be turning everything over to Dr. Mary Dalton.
Hi, good evening, everybody. And thank you very, very much for joining us. We're so delighted to be with you here this evening and to answer your questions. And I'm joined today by three of my wonderful colleagues, Dr. Zev Williams, who's in charge of our Columbia University Fertility Center, Dr. Cynthia Jomfy-Bannerman, who's our Vice Chair for Faculty Affairs, and Dr. Dina Goffman, who's our Chief of Obstetrics. And they have contributed so much to the knowledge about COVID-19 since actually almost a year ago. March 11th last year, COVID-19 was defined to be a pandemic. We've learned a lot since then, and especially since the vaccine became available. Myself and my colleagues have noticed that many of our patients have multiple questions, and We've held some webinars for some of our staff at Columbia, and we thought it might be a good idea because so many of you have questions to host this webinar this evening to answer some of your questions. And some of you have sent us questions already tonight, and we thought we would start with those, and then we'd be happy to answer any questions. And we'll ask, I will ask, and I will moderate this evening and ask the most common questions that we get asked about the vaccine. I'm going to start first with Dr. Williams. And Zev, thank you very much for joining us and all you do for us at Columbia. Can you just answer for our group tonight about whether the vaccine is safe for women who are trying to get pregnant or who are undergoing fertility treatment?
Thank you, Mary, and thank all of you in the audience and all my colleagues who will be presenting today. I think, for many of our patients, this is a time of such anxiety and worry, and as is often the case, knowledge and information and giving the best information we have can go a long way of helping it. Fertility seems to be, even at baseline, a source of a lot of fear and worry for people. And when you overlay that with the pandemic that we're having, the many unknowns and the new vaccines that are coming out, it really creates sort of a perfect storm for a lot of fears and worries. And now we have social media that often will amplify those concerns. So I think your question, Mary, is a very helpful one and a very timely one because there is a lot of misinformation out there. What we know right now is actually quite reassuring. Despite what many people might have read on Facebook or on other sort of social media platforms, there does not appear to be a link, an association between the vaccine and infertility. And to take it even one step further, the concerns and the fears and the basis for a lot of that, specifically the concern that the vaccine triggers an immune response that will also target some of the proteins that are important for pregnancy, that just doesn't bear out in terms of how the actual biology works. So there isn't data to support that, and there isn't really a biological basis to support it. So I think for many people, the advice that we would give is that if you can get the vaccine, if you're eligible for the vaccine and you're not pregnant and you're planning to get pregnant, you should get the vaccine if you're able to. The fears that it might interfere with future fertility, thankfully, seem to be unfounded.
And Zev, can I ask you, there are also questions about male infertility. Could you also comment on any potential link between the vaccine and male infertility? I know I get asked that question, and I usually defer all of those to you and your colleagues.
Yeah, thank you. And you're right. These questions, the fears about fertility apply to women and men. I think the way you phrased it, Mary, is really important. There's two separate things. The questions about the role of the virus and male fertility and female fertility, so the actual infection, versus the role of the vaccine. And the two sometimes get conflated. It does not appear, just like in the case of female fertility, there does not appear to be an increased risk for any male infertility due to the vaccine.
Great.
So it appears safe.
And Zev, could I just ask you, in terms of when women are thinking about undergoing infertility treatments, like how soon should they get it in relation to fertility treatments, if they are eligible, if they're eligible for the vaccine right now, or does the timing make any difference?
I think in general, the sooner the better. And the reason is, the sooner you get it, the sooner you get the vaccine, the less likely you'll be to get the actual infection, to get the actual virus. So I would certainly not recommend delaying getting a vaccine. And if anything, if you can get the vaccine even before one becomes pregnant, that might be advantageous as well. So certainly would not hold off getting the vaccine. Sooner better than later.
Great. Thank you very much, Zev. And now I'd like to just change the conversation and ask Dr. Gyamfi Bannerman, who's been very involved in the national recommendations about COVID vaccine during pregnancy. And our organizations, of course, the CDC and our national societies have come out with recommendations that leave a lot of the decision-making to the patient in consultation with her physician. But Cynthia, could you answer like the big question, is the vaccine safe in pregnancy?
So I'll start with a little bit of background in that, in general, clinical trials that are done outside of pregnancy, so for drugs, treatments, everything outside of pregnancy, will exclude pregnant women. That's a historic issue that's beyond the scope of this conversation, but so it's not unusual that pregnant women were not included in the Pfizer or Moderna trials. So from those trials, we don't have specific data to say that the vaccine is safe. But I can explain to you a little bit the process of how these vaccines got their emergency use agreements. And in that process, in fact, we do have some data to suggest that it is safe. They perform, both Pfizer, Moderna, and Johnson & Johnson had to perform animal studies looking specifically at fertility, teratogenicity, any mal effects towards the baby, the mom, and all of those data showed safety. Additionally, there were a handful of women, probably about 30 to 35 women, who became pregnant during the course of the trials. And there were no adverse outcomes looking at them by whether they're exposed to the vaccine or not. And I just want to briefly show you how the vaccine actually works, because I think that that might be helpful in understanding. So I'm just going to share my screen for a second, and I'm going to show you the slides. So hopefully you can see that. But basically, first, let me show you the very beautiful and very deadly coronavirus itself. And what you can see here, I don't know if you can see my mouse, but these very pretty red spikes on the bottom left here are actually what the coronavirus looks like. And the mRNA vaccines, what they do is they're directed towards these spikes. So that's the outside of the virus. And what they do is they make information that is similar to the spike, such that then your body recognizes it and then forms antibodies. Because antibodies is what we all want. We want antibodies to the virus so that if our body sees it, it'll attack it. And so the vaccines are really targeted towards those beautiful spikes. If you look at the bottom right of the slide, really importantly, the vaccines aren't live. The viruses aren't live viruses. These are not live virus vaccines. So you're not getting coronavirus or COVID. They don't go into the nucleus of the cell. They don't in any way change your DNA. I know that it's sometimes scary to see mRNA vaccine and what is it doing to me, but they don't alter your DNA in any way. And they can't cause any genetic changes within you or within the developing fetus. And I think that part of it makes it really reassuring to patients. And then I just wanted to show you actually one other slide. Suffice it to say that the Johnson & Johnson one-dose vaccine is very similar to all of the other vaccines. So it's not an mRNA vaccine. So you guys are much more familiar with those types of vaccines. But recently, the CDC has published their V-Safe data in pregnancy. And so when you get the vaccine, what you'll be asked to do is participate in this V-Safe surveillance from the CDC, and they text you every so often to see how you're feeling. And actually, when I got the vaccine in December, I enrolled in the program, and it's just a couple questions about how are you doing, et cetera, et cetera. And so there are actually 30,000 pregnant women who have received the vaccine so far, but about 1,800 of them have enrolled in the V-Safe program, and these are outcomes from completed pregnancies of about 275. So very important to see here, look at the top row, you can see that the rate of miscarriage in the vaccine group is very similar, if not potentially a little bit lower, to the background rate. So it's important to know that there are background rates of all of these pregnancy outcomes. And in the group of women who got the vaccine, there was no difference. So this, again, is more data now that's newer and I think very reassuring in terms of pregnant women who are vaccinated don't seem to do any differently than pregnant women who were not vaccinated or historically. So I know it's a very long answer, but I wanted to show you some data about why we think the vaccine is safe.
Sorry, I went on mute. I apologize. Can I just ask you, You mentioned in the beginning about how pregnant women are usually excluded from trials of drugs and vaccines during pregnancy. And now that's changing. And could you share with us what current vaccine trials are going to happen in pregnancy?
Yeah, so I think both Pfizer and Johnson & Johnson are doing their due diligence, and both of them have introduced vaccine trials in pregnancy. I know, and we're participating in both, in fact. The Johnson & Johnson study, neither are ready to start yet, but both are very close. The Johnson & Johnson study is open label. The nice thing about being a pregnant person and participating in a clinical trial, I can tell you from the framework of someone who does a lot of clinical research in pregnancy, is that you get your own study coordinator who then checks in with you all the time, weekly, who knows exactly how you're doing, and you can communicate with them in a way that you can't if you were a member of the public and not in a clinical trial. So for women who enroll in the Johnson & Johnson study, it's open label, you know what you're getting, and you get followed very, very closely. The Pfizer study, they're still working out the details. I think they may still be using a placebo. So if you are someone who would like to contribute to science and participate in that, you can. Otherwise, you can also kind of decide that you want to get vaccinated outside of those trials.
Great, thank you, Cynthia. And we should be starting those trials at our center in the next month or so?
Yeah, within the next month, I would say.
Okay, that's really fantastic. And I know you have been a major advocate of including pregnant women in trials. So we have the information for pregnant women at the same time as we have for the general population. So thank you for all you do there. And the other question I frequently get asked is, if you are going to decide to take the vaccine during pregnancy, is there some time that's better than others? Are you worried about the first trimester more than the second or third trimester? And if you could share your thoughts on that.
So when we wrote the recommendations, we very specifically didn't point to a trimester for a couple of reasons. First, because there wasn't research into which one would be better. Second, because the vaccine does act very locally and then comes out of your system quickly, and you just form the antibodies. But thirdly, there wasn't a biological reason to think it would be different between trimester. The data I just showed you from the CDC and from VSafe kind of confirms that. So the rate of miscarriage was not different in both in the group who were vaccinated compared to women who are pregnant and not vaccinated. Important to know, the rate of miscarriage, as I'm sure most of you know, is pretty high in the first trimester, which is why we don't tell our coworkers or other people until outside of the first trimester that we're pregnant. So it's about 1 in 4 to 1 in 5. And we didn't see a difference between pregnancy and non-pregnancy. So there really isn't a specific trimester that you should get vaccinated in. Importantly, you should try to space out vaccinations in general. And so the recommendation is to wait about 2 to 3 weeks after getting one vaccine to get another one.
Yeah, I would just add, can I just add to the first trimester question? We've had a bunch of conversations about this with various patients, family members, friends. And I think the first trimester issue is complicated because miscarriage is so common in the general population. I think what we would never want to see is a patient to be vaccinated and then believe that a miscarriage that may have happened anyway was in any way related to the vaccine itself. And so I think that may be a reason that there are some conversations or doctors in the community that are suggesting perhaps to wait beyond the first trimester. Not that there's science to support it, but just from sort of a common sense and logic and sort of thinking about the patient's perspective.
Yeah, I certainly have seen that in my own practice, and especially I see this in women who've had a previous miscarriage, because clearly they've gone through everything that happened on the day, and could they have done anything? And they really question themselves about what could have happened. And I think they are very nervous about getting the vaccine in the first trimester. And I think one of the things I always think about is how are our patients feeling about the vaccine? Because ultimately, from the recommendations right now, it's our patients and women who are pregnant that will make the decision for themselves, given the information that we have. So, Dina, thank you for bringing that up. And Cynthia, can I just ask you what you're seeing in your practice related to the vaccine, since pregnant women became eligible, if you will, to receive the vaccine?
Yeah, that's a great question. I would say initially all of our conversations were very theoretical about when the vaccine would be available, what would we do. But interestingly, in the week that the governor allowed for pregnant people to be vaccinated, the difference was quite remarkable in that several patients said, I need to get scheduled. I need to immediately get scheduled because once I deliver, I realize that I'm not going to be a priority in a priority group. And I'll have to go back to the kind of end of the line before I get vaccinated. So it was interesting in that I saw that, and there's a broad kind of variety of what people want to do. Some absolutely want to get vaccinated and as quickly as they can. You know, looking at your personal risk and your personal exposures and your home situation, I think all of those things come into play. But yes, there definitely are others who are a little more hesitant and are willing to wait and who might be in a situation where they're very unexposed. So the changes were remarkable.
So in general, when I'm speaking to patients, I talk about what is their own personal background risk. You know, how exposed are they? Are they working from home? Are they seeing anybody? Versus some of the patients that we see in our community who it's not possible for them to socially distance. And in that situation, I would veer more towards getting the vaccine and talk to them about those risks. And of course, the second thing I think about is their individual medical risk. If they're diabetic, if they're obese, if they're hypertensive, then if they do get COVID, their risks of getting a significant infection during pregnancy is more serious. So in general, those are the discussions that I'm having with patients, is talking about their individual background risk in their community, and then talking about their individual risk for the potential, as we call them, comorbidities, but other medical conditions that they may have during pregnancy. And I find in general, that's helpful to the patients that I see. Sorry, Dina.
I was just going to add to that. I think important background for this in terms of understanding why pregnant persons were even put on the list of being potentially eligible at this point is because we've learned over the course of the last year that pregnant patients who do get COVID-19 actually get sicker than non-pregnant, similar aged women, you know, and while the risk is elevated, you know, it's not intended to scare people. Certainly we see pregnant women who get COVID-19 and do well, but we know that the risk of needing to be in an ICU, needing to be on a ventilator, some of these really scary outcomes are actually increased in pregnancy. So I think that's where our conversations, where we talk about patients' individual exposure risk, commuting situation, work situation, number of people in your household, have to be weighed against what might happen if you in fact do get COVID-19. So I just think that's important background.
And Dina, in general, what I've been giving is, and I'd like to just confirm this with you and Cynthia right now, is that if any of our pregnant patients do happen to get COVID, the absolute chance, if you will, of them getting a significant infection that would require admission to an intensive care unit, or they would need to be put on a ventilator or ECMO, would be about 1 in 1,000. Do you think that risk is still what we should be quoting?
Yeah, I think that's fair and a fair estimate. I think if you look at ICU admission, the numbers in the literature are higher than that. But I think often with a pregnant patient, we would admit you to the ICU as a precaution for close monitoring. Those are about 10 in 1,000, or 1 in 100. And then the others, I think, are more in the 1 to 2 per 1,000 for these really serious outcomes, needing to be on a ventilator or, you know, an actual patient death. So I think those are really rare, but they're still higher than if you were not pregnant. So it's figuring out how to balance that information.
Yeah, I think importantly to remember for the audience is that the absolute risks are low, and the majority of women, pregnant women who get COVID, are either asymptomatic or have mild illness. But because the risk is higher than if you weren't pregnant with COVID, it's something to think about as you're considering whether or not you should get vaccinated.
And our team were one of I think the first to publish the incidence of asymptomatic COVID infection during pregnancy, because last March, we started testing everybody on our labor floors across our NYP system. And what we found at that time was that almost 90% of our patients were positive, had no symptoms whatsoever. So that has allowed us over time to make sure that we test every pregnant patient who comes into who's admitted to our hospital or comes into our labor floor. So that really changed how we were thinking about COVID when we found that out in the very early days of COVID. And very grateful to our hospital and to our labs that supported us to test every pregnant patient at that time. And Dina, could I just ask you, one question that, again, we frequently get asked because a number of the population have already had COVID. I think among the women we see, 35% or so is the figures we saw today, have had COVID or have had COVID antibodies. Should they get the vaccine if they've already had COVID?
I think it's a great question, and it comes up quite often for us, in taking care of patients and speaking to our colleagues. And I would say the general answer is if you've had COVID, the recommendation is still to be vaccinated for COVID at this point. And it seems like there are a number of questions about that in the Q&A as well. I personally had COVID in March early on in this and couldn't wait to get my vaccine. Having antibodies, we don't know what the threshold is in terms of how much antibody do you need to be protected from a potential exposure. So I think we just don't know what those thresholds are to be protected. I think when you had COVID, certainly in the first 3 months after an active COVID infection, probably the urgency to be vaccinated is lower. But what we're recommending here is once you're out of your infectious window, so 10 days from a positive test, is when you're now eligible to come in and be vaccinated. So we're not recommending that you must wait. I think those conversations may change depending on pregnancy, where you are in pregnancy, when we anticipate delivery, and it would go into those individualized counseling conversations to really help come up with what's best for each individual patient.
I think another unknown for pregnancy, and when they've had the COVID during pregnancy, I find most are not interested in having the vaccine straight, within 10 days afterwards. But I think that is something that we'll need to continue to do research on and see how our patients are feeling about that and see what the outcomes are. And the other thing, of course, is breastfeeding. Dina, can you just share with us if when a patient says, I've recently given birth, I'm breastfeeding, should I get the vaccine?
Yeah, I think this is a really interesting question for us right now, because I'm sure all of you will recognize that being postpartum or breastfeeding right now does not make you priority and doesn't make you eligible at the moment to be vaccinated. But I think all of our societies, all of the literature we've seen certainly recommends that the vaccines, all of the vaccines that are currently available, should be safe in breastfeeding. Dr. Gyamfi-Bannerman mentioned that where these vaccines are given, they're really degraded locally very, very quickly. So the chance of anything in the vaccine making it into the breast milk is slim. And even if it were ingested orally, if the baby did get something, it would be broken down, in the GI tract, in the stomach, by the stomach acid. So the chances of the baby having any impact from mom having been vaccinated in a negative way would be slim to none. And on the flip side, what we do know now, there's actually evidence out there that the antibodies that we're all anxious to have actually do pass to the newborn through the breast milk. So I think that's really exciting. And for me, makes vaccination in breastfeeding patients is really important.
Great, thank you, Dina. And the antibodies, the issue of the antibodies, will breastfeeding pass the antibodies on to my baby?
Yes. I mean, it's small studies now, but we've all seen since the vaccines are out there, number of women wanting to donate their breast milk and have their breast milk studied. And so I think that is increasingly becoming available, that we actually do have the data that the antibodies pass to the breast milk. So I think that's a real positive.
That's fantastic. And question for you, Dina, and Cynthia, and we saw our own data today. How often are women delivering in our system now that are positive for COVID?
Yeah, so we've watched our data very closely week after week for the last year, believe it or not. And we've seen the numbers wax and wane. I think everybody's watching this, story unfold across the country and seeing some really hopeful data about numbers decreasing in the rest of the country. The numbers are decreasing here, but it hasn't been as rapid. So I think that's the really good news. Dr. Dalton also mentioned that we're testing a lot of women routinely when they come in to have a baby, and that's a safety reason. We want to make sure that everyone has this information, that we're using all the necessary precautions, that we're protecting moms, babies, staff, family members. So we see women who are asymptomatic and swabbing positive, and we sort of take that for what it is. We still see some women coming in sick with COVID-19, but the numbers are nowhere near what they were last spring. So we're still seeing it, but.
And something that I find very reassuring to tell our pregnant patients is that we have delivered now about 500 babies or so with COVID-19 who have either been active or had it had it in the past. And we have not had one of our babies affected. So clearly moms they don't worry about themselves as much as they worry about their babies. And our neonatal intensive care unit and our pediatricians have done an absolutely fantastic job and really provided very safe outcomes for our babies. So that's really been a very positive story to tell to our pregnant moms.
And
I
I think
can add to that a bit in that it's that's in the context of allowing breastfeeding, direct breastfeeding. It's in the context of hand hygiene and breast hygiene, and very close follow-up of the babies of COVID positive moms for kind of weeks on end. In fact, we're funded to follow them for quite some time. So we can kind of definitively say that we haven't yet had any case that appears to be a vertical transmission.
Yeah, I think that's a really important point. I think early on in the pandemic, there was a lot of concern about, do moms and babies need to be separated? We never did sort of routine separation of moms and babies. And I think through not doing it, but using a lot of precautions, everything that Dr. Gyamfi mentioned, hand washing, being cautious with breastfeeding, masking, all of these other things, we've really been very successful at keeping babies safe. And I think that's a real success story.
So we have a number of questions in the Q&A, and because I haven't been able to read them fast enough as I've been asking the questions, Aliza has offered to ask the questions that are in the Q&A. We will all answer them as best as we can. Aliza, thank you very much.
Not a problem. Yes, the questions are coming in fast and furious here. So people are asking, how is the COVID vaccine the same or different from the MMR vaccine, which is generally not recommended during pregnancy?
Oh, I can take that one. So the COVID vaccine is an mRNA vaccine, at least the most common ones. And so the whole methodology of how they're made are different. They're not live attenuated. So we don't give live attenuated vaccines in pregnancy, meaning that we don't give any portion of a live virus to a pregnant woman. And that's why we haven't given things like MMR and certain forms of the flu vaccine that are live attenuated. We don't give those. So this is actually not the virus at all. It actually just encodes for something that looks like the outside of the virus. And that's for the Pfizer and Moderna. The Johnson & Johnson uses a vector to introduce the genetic code, again, for just the outside portion of the virus. And so that's the difference. There's no live portion of the coronavirus given to the mom.
Perfect.
Great, thank you, Cynthia.
Another question that we have here is there any data available about if you received the first dose and then you found out that you're pregnant and then now you have to get the second dose? If, people are wondering if they should still get it.
I think the best advice is to continue with the second dose We don't have robust data about pregnancies between doses, just because, again, we just have data on about 300 completed pregnancies. But we know that in the way that it works, you do need, at least depending on the vaccine you're getting, you do need to have the second dose in order for it to reach the maximal efficacy. After the first dose for both of them, it's about 50-50. And so what we have been doing is recommending that they complete the course.
Yes, I've been doing the same, and patients who have found out they're pregnant early on and they had the vaccine, usually they're healthcare workers in the beginning, we're always a little nervous, should I go ahead? But if you've already had the first part of it, my recommendation is to go ahead and have the second part to be fully immunized.
People are also asking, do we have any data, do we have additional data on maybe a particular vaccine over another one in regards to pregnant women?
The
I can
answer
take
is
that
no.
one as well. No, we don't. We don't have any specific data over one versus the other, just the efficacy of those three of the general population. And so I think we all recommend that if it's available, whichever one is available to you is the one you should receive.
Yeah, I would just echo that. If you've chosen to be vaccinated and you can get vaccine, I think we don't have any preference at this point for one over the other. I think we certainly know that one is a one-time versus a series of 2 doses, but in terms of safety or efficacy, there's no data on that.
Okay. And then if a woman were to get COVID during pregnancy, how does COVID affect the baby?
So I'll take that. I think the general feeling in pregnancy is you need a healthy mom to have a healthy baby. We sort of think this about any potential risk in pregnancy. So it's not that COVID itself, that the virus crosses, there's certainly conversation around whether that's plausible, but anytime you have a mom that's sick, that's having difficulty with a pneumonia, with keeping their oxygen up, who's in the hospital, who has infection, it's the mom's illness that puts the baby at risk. And so things that we worry about would be, will the mom go into preterm labor? Will the mom need to be delivered because she's getting sicker and therefore you would have a premature baby, and those sorts of issues.
Okay. And then we're also seeing here, what role does one's age play in terms of getting or not getting the vaccine? For example, a couple in their late 30s or early 40s, if they're planning to get pregnant, would you be more inclined to recommend or not recommend?
So I think I'll start to address part of that. I think the area where time comes to play a significant role in fertility is that, unfortunately, the chances of being able to develop a healthy egg diminishes with advancing maternal age. And so the desire to sort of be able to push off trying to conceive, you want to do that less and less as the woman, but and to some extent the man as well, get older. The flip side to that, though, is if anything, I would sort of argue that says, so those people should be the most likely to want to get the vaccine, because certainly, God forbid, getting sick and having to delay trying to conceive because you got the actual virus would be detrimental. So I think for those who are in their late 30s or early 40s and anticipating trying to conceive, you wouldn't want to have things that could potentially delay it. And getting sick would certainly be one of those things. And so I think those would be couples, if they are eligible to get the vaccine, that should. There is a degree, and I know people ask about this, anytime you have something new, they're saying, well, how can you prove that doesn't have an impact on fertility? And it is always hard to prove a negative, especially early on, because we don't have 5-10-year data out. But at some point, it's important also, and it really behooves us to sort of ask why do we suspect that could be a concern? As Dr. Janfi Bannerman very nicely illustrated and described, the virus is an entity of itself with multiple proteins, 29 different proteins. The vaccine is of one of those. So I think if you have the option to be sure not to get the virus, that's great. And that's what we would all agree to. The unfortunate reality is in our world today, that doesn't seem like that's going to be the case for certainly the vast, vast majority of us. And so if you're looking at and especially you see when it comes to fertility, there's no reason to suspect that this virus would cause infertility. From a biological plausibility point of view, looking at other vaccines throughout history that we've used, there's not a reason to suspect that. And so now to have, I think hysteria might be an overuse of it, but certainly this widespread concern and people really not getting vaccinated because of something that's unfounded. So they're putting themselves at real risk for the virus for a hypothetical and not really that plausible risk from the vaccine. I think that does a disservice.
And I recall with great detail, Zev, when we were closed down, when our elective surgery was closed down and all of our IVF centers were closed down and we couldn't do IVF here in New York, that the distress on our patients was really palpable and remarkable. And you actually published some data on that. So maybe you could share that with the audience tonight.
Yes, thanks. Thank you, Dr. Dalton. And that's true. So in the early days, and last March, really about a year ago, when there was this very fast ramping up of cases, a very critical situation, certainly in New York City, there was sort of a pause put across in terms of fertility treatment. And you saw firsthand how devastating that was to so many women and couples. I mean, patients who would be telling us, I will, because there was a fear about traveling, they said, we'll sleep on the sidewalk. And for many, so to actually quantify this and to help inform policymakers, other patients, other healthcare providers, we did do a survey looking at patients' responses. And for many, many, having to postpone or cancel a cycle was considered the equivalent to losing a child. It was that devastating to them, and it meant that much to be able to go forward with them. So we're very thankful and appreciative from the support, certainly from Dr. Dalton, from the community in general, that fertility treatment is now thankfully going forward. And the virus is not going to be having sort of that additional negative impact for many women and couples.
Thank you, Zev. And Cynthia, there is a question about the initial data that's available from the VSafe program. Is there any concern with the stillbirth rate?
No, so I'm just looking at it again, and it looks like they were statistically similar. So a little over 0.5% and 1%. They seem to be very similar. This is a little bit of a biased sample, and so we don't have kind of full data on all of the women that are vaccinated, and certainly there's a difference for women who are motivated to put their information into VSafe versus those who aren't, and they might be entering them for a variety of different reasons, but I would say it's statistically similar.
I also think that we just don't have enough data because the stillbirth rate in the US is, about 1 to 2 per 1,000 or so. And this number, we're going to need thousands of patients with information on to be able to answer that question. But certainly what we have available, there is no signal. And Dina, one question that is here is, I'm concerned about possible developmental delays or disorders that the vaccine may cause to my future children because there's no longitudinal data to confirm or rule out these possibilities.
Yeah, I was trying to answer some in the chat just because I know there's no way we're going to get to these 74 questions, but I recognize that this is sort of a recurrent theme, and the fact that we don't have long-term data nor experience with this type of vaccination. I think what I would go back to is sort of how Dr. Janfi Bannerman started with showing how these vaccines work. They have very few ingredients in them. The ingredients are things like a lipid, which is like a soap bubble, some saline, which is like salt water, some mRNA, which is this little material that sort of fools your body into making an antibody to the spike protein. So I think if you look at what's in these vaccines and then the fact that they're degraded very quickly where they're given and sort of doing the job that we want them to do, we can't prove it to you, because exactly how we started, this wasn't included in the trials, but the risk of that material or anything in that material sort of getting to the fetus and causing long-term harm, I think it is really, really tiny. I think the other thing patients have asked about is, well, what about if I get those terrible reactions or symptoms or side effects from the vaccine? And certainly we know people are having side effects. They seem to be similar in pregnant patients to the general population, but some people will have headache, fever, chills, body aches. But we know those can be safely managed in pregnancy. We can use Tylenol, hydration, rest, and all the things that we would recommend for other patients. We would recommend Tylenol over ibuprofen for pregnancy-related reasons, but we're not concerned about those sort of routine side effects causing harm to the fetus either. I don't know if Dr. Gyamfi wants to add anything.
No, I mean, the only other piece that I would add is that it's, the literature on vaccines in general and developmental delays is poor at best. And so I wouldn't say that this is going to be any different from that. I don't think that we have any definitive evidence to prove that there is a link in the first place. So.
Great. Zev, I know you have done a lot of work with recurrent pregnancy loss, and you have a vast experience in recurrent pregnancy loss. And one of the questions is, in your patients who have recurrent pregnancy loss, what would your recommendation be?
Well, I think it's a tough question, and it harkens back to the point that Dr. Goffman made before, where it is very human, very natural, incredibly common for people after a loss to sort of look back onto the days, and as you mentioned, Mary, the days and weeks prior to that loss. What did they do? Did they go on a trip? Did they have a stressful event? And attribute that to the cause for the loss. I think the reality, though, is for cases, especially of recurrent pregnancy loss, those are not the type of things that cause the losses. And I would be far more worried about the virus and its potential to cause harm, either short-term or long-term, than I would be for the vaccine. So I think there's an important point in terms of counseling to the patient to balance their risk of gaining the virus versus what can happen from the vaccine. One point, and I did see this in the Q&A, was, first of all, it's amazing to be hearing from really the experts and all the events that go on through pregnancy. To take it to one step before, at the time of the embryo transfer, someone had asked about the vaccine there. And that sort of ties into the question of loss. As we've heard, the vaccine, especially the second dose, but sometimes even after the first, does often cause fever and sort of those types of symptoms, mild, but still present. I think people would be cautious about doing an embryo transfer and putting the embryo in right around the time that someone might spike a fever and things like that. So there we're just dealing with a couple of days. And in the very, very early pregnancy period, that might be the only time where I think, at least for right now, a little bit of caution would be reasonable. For recurrent pregnancy loss patients, though, it's often a question of really carefully looking and investigating to find out why the loss has been happening. But if you can avoid other things from causing it, such as getting a severe illness, that helps.
Great, thank you, Zev. And Cynthia, there's a number of questions on here about the trials. And for those who are interested, how can they sign up for that?
So I'll work with Elisa maybe to give you the information from my research coordinator. Her name is Carolyn Torres, and she loves to receive emails from people who are eager to participate. So we'll make sure that you have her email information, and then she will let you know once we're ready to enroll.
Great, and we can also give that information to Elisa, who can send it out about how they could join in the trial.
If you're interested in joining, feel free to email me. All of you have my email address, and I'll make sure to compile a list and send it over to you guys.
Perfect.
Great.
No problem.
Thanks very much, Elisa, for all your help this evening as we do a Zoom with so many people on. So thank you, you've been terrific. Dina, can I ask you, when in the postpartum period would you recommend getting the COVID-19 vaccine? After you have your cesarean delivery, how soon after? Many questions about that.
Yeah, I was just looking at a few of those in the chat. So I think the first thing is that obviously as soon as you've had the baby, there are immediate things that we're helping with in terms of recovery in the hospital. And currently we're not able to do this vaccination as an inpatient. So I think the immediate recovery, those first couple of days while you're sort of getting everything else sorted out. I don't think there's an urgent or pressing need to be vaccinated then. I think some of the rest of it goes to what are your risks? What are you going to be doing immediately when you go home? But I think certainly, especially if you're breastfeeding and wanting to be able to provide some antibodies and protection to the newborn, I think if you're eligible, and again, that this will change over time. Right now, if you're postpartum and otherwise healthy, you wouldn't be eligible to be vaccinated. But I think if you have any of those comorbidities or medical conditions that are on that list for New York State, or if you live in the surrounding areas, each state has slightly different approaches to this. So I would just encourage you to think about what will your situation be in terms of exposure risk in that immediate postpartum period, and will you be eligible to be vaccinated to start to make those decisions.
Great, thank you. Zev, I know this is something that we've talked about before, is that when you get the vaccine and the second dose of the vaccine, you may get a fever, and what are the issues with that in the first trimester, especially the issue of a high temperature with first trimester, and would it be better to wait until the second trimester?
Yeah, it's a tough question. Certainly, and you know, if we have the choice between, and this is, I think one of the themes that you're hearing over and over again is a question of sort of balancing risk, balancing what we know from what we don't know. And it's not a question of absolutes. We can't say with absolute certainty that this vaccine won't cause infertility, but we have no reason to data supporting it does, and sort of studying what we've said before doesn't make us think or have reason to suspect that it would. And the claims that have been out there seem false. The question with the early pregnancy, again, if it was an option, and if someone can be in a very safe and protected environment where they're not worried about, where they're really able to isolate and they're able to be remote and not have sick contacts, there is the concern earlier on about whether that type of symptoms, the fever, you know, we'd obviously prefer people not to have those types of symptoms, not to have a fever early in pregnancy. But I think the actual risk from that, you know, we know people get colds for lots of reasons and have low-grade fevers for lots of reasons, and you don't see a lot of pregnancy losses happening as a result of that. This, if anything, would be more mild because there's not an active virus as there would be when people get a regular cold or flu. So I really, you know, I think it's a question of balancing the things. We do certainly need more data, but since we're living in the real world and people can't say, okay, I'll wait 5 years to then figure out what I'm going to do in the first trimester, I think people have to really have an open conversation with their provider so they can assess what's the risk of delaying versus the potential risk, which I think is quite small, but the potential risk from getting it and having significant symptoms. Again, I think those would be very, very small. Do we have data to support that from these vaccines? Not yet, but I think it is going to be exceedingly low. And as Dr. Gianfranco Batterman said, that data is being accumulated and collected quickly and being disseminated, and that kind of work has been only reassuring.
Great. There's a question on here which I think doesn't relate to just the COVID information about the COVID-19 vaccine, but how to reconcile different opinions from different providers. And unfortunately, we see that a lot, and it leads to enormous anxiety for the patient because they say, who should I believe and what is the information? And it just leads to so much anxiety and uncertainty. And there's one question here. When I got the vaccine, the nurse said to me to wait 2 months to try and conceive, and the OBGYN said 2 weeks after the second dose. So for a patient, how do they reconcile that?
I can take that one. I mean, I think that, so consider that 4 or 5 months ago, this vaccine didn't exist for public consumption. And so the data that we have is very recent, and there's not a lot of information about what should be done. So this is a little bit different than other more, I guess, known, tested, reliable vaccines. So we don't have a lot of information, and a lot of people are giving kind of their own opinions about what they think is the right thing, rather than based on data, because we don't have a lot of data. But what we do have, importantly, is in theory and in the animal studies and in all of the things we've talked about, there's no reason to think that there would be harm towards getting the vaccine. I think one piece that's very helpful for patients is to go to the website for ACOG, which stands for American College of Obstetricians and Gynecologists. It's just www.acog.org, and I'm going to put it in the chat. I think it's helpful because they have patient-facing questions and answers, FAQs. And you can go through and see what the specialists, the folks who have written all of the guidelines, what the recommendations are. You see wide varieties in what people are recommending because there's no standard. And we're trying to work to develop that standard. But in all of the information that we had, and many of us, like Dr. Dalton said, were involved in writing these guidelines, certainly there was no granular information about 2 months, 2 weeks, and people are providing their opinions. But if you want kind of a independent opinion that's based on expertise, national expertise, that's a great website to go to get your questions answered as well.
That and the CDC, and the CDC now has, I think, been gaining a lot in confidence over the last few weeks, and we have a wonderful new director of the CDC. So really looking forward to the transparency of information from the CDC that we've really relied upon over many years, and probably didn't have its finest days in the early days of COVID, but that's certainly being turned around right now.
I really liked Dr. Jennifer Benjamin, your suggestion of ACOG. I think that's really, really great and helpful for people for pregnancy questions. For those who have questions about fertility, sort of the pre-pregnancy period, another great resource is asrm.org, and I'll also put that in the chat message area. And they have a separate section for patient questions. So I'll add that as well.
And these information, as it becomes available, is being updated. I think it was last updated by our society in early March, Cynthia from our Society for Maternal Fetal Medicine. And then from ACOG, you know, it's kind of every week they send some updates. So it's very, very helpful for those of you who want to stay up to date with what's happening. The time is 6:56, and I know everyone has been incredibly engaged this evening, but I was just going to ask each one of the panelists, I'm probably putting you on the spot, but to give a take-home message, one take-home message to our panelists. So I'll start in the order that I started off, and by asking you, Zev, what would be your one take-home message for patients who are thinking of getting pregnant or undergoing fertility treatment right now, where we are with COVID and the information we have?
I think for those who, and thank you, Mary, for that, and to all the panelists, I always learn a lot just listening to all of you. I think the message is actually a very, very reassuring one. There is so much fear in general and anxiety in general about fertility, future fertility. And I think the data is actually very reassuring that a lot of the fear that is out there is unfounded. And I think people can confidently go to say, based on the data that we have, that getting a vaccine is certainly the safest option that exists and the best way to protect you. And potentially even protect your future fertility if there are issues from the virus that we still have to learn about.
Great, thank you, Zev. Cynthia.
First of all, thank you, Dr. Dalton, and everyone for listening to us and having us on the panel. I would say that the decision to get the vaccine in pregnancy is a very personal one, and you really need to think about your personal situation. So if you are taking care of an elderly parent, or you have a child with asthma, or you're commuting to work every day, you might have a different answer than someone who maybe works at home and doesn't go to the grocery store and hasn't been outside in weeks. But I do think that the data we have are pretty reassuring. And so if it were me, I probably would get vaccinated.
Okay, thank you, Cynthia. And Dina?
Okay, so last is toughest. I think I would say that I would just echo that there's not a right answer here. It's definitely not one size fits all. I certainly recognize how stressful it is to be pregnant, to be a new parent, to be breastfeeding, and to sort of recognize that every single thing you do, you're worried about your newborn and your pregnancy. And so I think those feelings are all very, very normal. And that's why it's not going to be the right answer for everyone, and I know we sound a bit like a broken record, but I think it depends on your situation. It depends on your exposure risk. It depends on your medical history. It depends how far along in the pregnancy you are. Are you going to be delivered in 2 weeks or in 22 weeks? Because that's a big difference in terms of keeping yourself and your pregnancy safe. So I would just say, don't hesitate to ask questions, read about it, learn about it. And I think whatever you decide, my takeaway for everyone, and my team gets tired of hearing it from me, is that we just need to stay vigilant. You need to continue to be really cautious with hand hygiene, with social distancing, with masking. I know it's been a long year and we all have COVID fatigue, but we really just need to keep ourselves and each other safe. And so I think in addition to thinking about vaccination, we're thrilled that you're here listening, typing in your questions. It means everyone's really going through that process, and we're here to help.
As I frequently say, we're done with COVID, but it's not done with us. So, over the last year, we've all seen the really importance of mental health to everyone. As we've all dealt with this pandemic in our own ways, we've certainly seen our frontline healthcare workers experience the fear and have overcome that to look after our patients to the very best of their ability. But for women thinking of getting pregnant who've had infertility issues, and for our pregnant women, the anxiety is palpable. So we recognize that, and we hope that although we don't have all of the answers for you tonight, that we know at least what is the most up-to-date available information that there is, and we will continue to have that. And we're always happy to go over this again with you in our offices, but we thought that this might be helpful for you tonight, as we were getting some of the same questions in our offices. And there will be a link with the recording, and we will provide the clinical trial information and all of the suggested sites that my wonderful colleagues have shared with you tonight. We will be sending you by email tomorrow. So thank you to my wonderful colleagues. Thank you to Columbia New York Presbyterian and everybody who has helped us put this together. And most importantly, to all of you for joining. We hope you have a wonderful evening, and thank you for your confidence in us. Okay, bye everyone.